Well, some of you may or may not have been at my talk yesterday, or might have heard me speak at other times. But first of all, I want to say who I am. And I do represent neuro needs, and the booth is over there way on the other side of the place if you want to talk to me. But I'm also, my day job is as a clinician. I've been seeing patients with autism and other neurodevelopmental disorders for now a quarter of a century. And I was at Children's Hospital Los Angeles and faculty at USC in Los Angeles for over 20 years, and I've been in private practice now for 5 years in Pasadena, California, and I also have a telemedicine practice that works out of New Jersey, the Philadelphia metropolitan area. And I will go over that a little bit later on that. I've also worked for DNA sequencing companies as the medical director, done research, legal consultant, a lot of Munchausen cases, and assorted other things. So I come to this wearing many different hats, but today I'm coming to you mostly as a physician that has seen very large number of patients and discussing what I've seen and what works. Disclosures, the usual is that this has not been vetted by the FDA. Everything is off-label pretty much in pediatrics in general, and in this talk the medications that I will discuss using in various patients were based upon the individual genetics of that patient and are off-label. In addition, I'm going to be talking in the last few slides about a program that I set up in order to try to interpret the DNA testing that you may or may not have had or hopefully will get if you haven't had it already. Okay, so this is an autism talk, but I want to start with a patient who's neurotypical, patient that doesn't have autism. Peyton came to me at age 11 years. She had had cyclic vomiting syndrome for 10 years. If you don't know what cyclic vomiting is, it's actually pretty common. Up to 2% of school-aged children have it, and it's not that uncommon even in adults. It's when you have episodes of nausea, often with vomiting, but nausea is the worst thing usually, and lethargy. Abdominal pain is very common in it. Some patients get headaches, some patients get diarrhea, other problems, but it's really nausea, vomiting, and lethargy that come in episodes, and the episodes can last a few hours or they can last even up to a week or more. And then the episode goes away, and you either don't have those symptoms between episodes, which is most common in children, or you have milder symptoms between episodes, which is most common in adults. But it's not exact in that regard. So she had that, and what often happens when you get it when you're very young is at the time of puberty, it goes into migraine headache. So she had daily migraine pretty much all the time. She had multiple admissions for bowel cleanouts. She was a very good student. But none of that was her chief complaint. Her chief complaint was her fatigue. Her fatigue was so incredibly severe that if she came downstairs to have breakfast, she was wiped out the rest of the day and couldn't do anything. But she was able to get good grades from her laptop on her bed. So we did DNA sequencing on her, and I found a variant in the TRAP1 gene. You say, okay, well, that's easy enough. You do the sequencing, you find it. This variant is found in 1% of the population. You say, well, that's not that rare, but it could be a risk factor. I put down here, just to give you an idea, the average patient has 3,000 genetic variants that are 1% or less in the population. So this is not, there's on the average of 3,000 of these variants. One patient might have 2,500, another patient may have 4,000. But there are 3,000 such variants. How do you take these variants that are extremely common, or they're very numerous, I should say, and then translate them to disease? And so that's part of what this talk is about. This TRAP1 gene is a chaperone. What it really does is it protects proteins in the mitochondria from oxidative stress. So when the mitochondria is not working very well because of mitochondrial disease or because the normal person is under very stressful situations, you have a lot of reactive oxygen species. And the chaperone protects the proteins from damage. And if the chaperone's not doing that, times of stress cause oxidative damage to destroy the mitochondria and end up with a mitochondrial disorder. The reason I noticed that this variant was important in Peyton was the fact that I had 2 other patients that had exactly the same problems she had that had the same variant. So I thought, there might be something here. It makes sense. And then eventually I collected over 100 more. So although there were many other symptoms these patients have, and I'll get to one in the next slide, chronic fatigue, chronic pain, and GI dysmotility were the ones, sort of the triad to suggest TRAP1 disease. So with the help of the colleagues at Georgia Tech, they actually took the entire Georgia Tech computer system the entire weekend working on this problem, and took every single molecule that could possibly exist and put it into the binding site of the mutant TRAP1 molecule. You see the little cartoon on the lower right? That's what the TRAP1 molecule looks like. At the bottom is ATP in green. There's 2 molecules there. ATP binds to TRAP1 and causes the energy. It allows the energy for the crab to grab a protein and hold it and keep it in place against oxidative stress. So I wanted to find a chemical, some sort of drug or supplement or something, which binds very tightly to the mutant binding site. In other words, the molecule that has the mutation, the protein that has the mutation in it, I wanted to destroy that so it didn't cause trouble and leave the normal TRAP1 to do its work. And the computer identified ganistotron, which is often used for nausea and vomiting. It's also known as Chytrel, as a good model. We gave Chytrel to her, and her problems pretty much melted away. Her fatigue became dramatically better. She was able to go to school half-time, not perfectly normal. Her pain went away entirely, and no more GI cleanouts. So that could give you an idea of the power of molecular analysis, but it's really the interpretation which is the difficult part here. So this is an autism talk. Why am I talking about a neurotypical? I had a lot of girls that had this problem, and their brothers had autism. Their brothers had the TRAP1 variant as well. And I saw this over and over and over again. In fact, I had been doing autism for 25 years, but this is one of the main reasons that I really got into it, is I noticed constantly that the patients that had things like cyclic vomiting syndrome that I had become an expert in, they also, in the family and often in the same person, had autism. So it suggests that the genetics which predisposed towards pain, fatigue, nausea, vomiting, also predisposed towards autism. And indeed, those symptoms are pretty common in the autistic population. So Carter was my first one. He's a relatively uncomplicated autism. Nobody is totally uncomplicated with autism, but at least he doesn't have a million other things like some of the other patients I'm talking about. He had the variant, and he was diagnosed with probable mitochondrial disease based upon metabolic biochemical testing. So we gave him Chytrel. And by the way, he had his autism started after the MMR vaccination at age 1 year, which is the environmental trigger. And Chytrel made a big difference in him. You can see the green here is the things that got better. You can imagine that the insurance company considers this, this is off-label use of Chytrel, way off-label. You can imagine what the insurance company will say about this, using a nausea and vomiting drug that's meant for chemotherapy patients to treat autism. So they denied it multiple times, and there was a nationwide shortage twice of Chytrel. To my knowledge, that Carter was off of this drug 4 separate occasions, and he did get worse each time, and he went back on, and he got better again. In fact, this drug makes such a difference that the parents would never able to go out to a restaurant. He would just make animal sounds, run under the tables, and there was just no way they could ever do that. But on Chytrel, he will sit and eat at restaurant and be good. The difference is amazing, and the school, every time that he went on or off of it, would say, "What's going on?" So I know this is not a placebo effect. So again, in the little blue thing on the bottom there, it goes to show you that the genes that predispose towards autism are not autism genes. They are genes that are involved, for the most part, in the development and the function of the brain, and often the rest of the nervous system as well, causing, GI problems is involved in the nerves of the gut. So there are additional problems even beyond neurology which sometimes happen, but the same genes that predispose towards autism are exactly the same genes that predispose towards migraine, towards schizophrenia, towards depression, towards intellectual disability, towards ADHD, you name it, epilepsy. They are genes that are involved in making a brain and operating a brain. So I show this just to mention that, it may seem like magic, but there's a lot of work that goes into it, and also my daughter likes her picture taken. This is the machine that does it. The Human Genome Project, where they sequenced the first person's genome. The genome means all the DNA, all 3 billion nucleotides. It took over a decade and cost billions of dollars. This machine can do it for $1,000 in an hour. The machine costs $1 million, that's true, but it's amazing what it can do. So the capabilities that we have to read the genes of people has gone dramatically. In fact, I figured out the cost per nucleotide. There's 3 billion nucleotides in our genome. 5 years ago, we were offering testing. I was in Cortigen at that time. For 10,000 times more money per nucleotide than we are today, than other labs are today. So it's gotten 10,000 times more cheaper. So what that means is we can sequence a tremendous amount more while the prices come down. Okay, I try not to get too technical, but you need to know something about variants. I might use the M word a few times here, mutation, because as an old geneticist, we used to talk about mutations, but no one wants to be a mutant, so we're not supposed to use that word anymore. If you hear that from me, it's just old things die, hard. But I will use it in one context. But anyway, we're talking about variants. Variants, there's tens of thousands of variants that each person has from the reference code. And variants, in the most part, do nothing. But many of the variants make us who we are. We're all completely individuals in many different ways, and it's defined by the variants. Some variants are related to disease. They make us more likely to get certain diseases or less likely to get certain diseases. There's certainly resilience variants in the population. And occasionally there's a variant which is very likely to result in disease, that it's so likely to result in disease that we might use the word causality or causing disease. But in reality, it's still increasing risk. There are people in the population that have variants that are considered to be causing disease, and they don't even know it, and they're completely normal. Because what our DNA does is it confers risk, not disease. So here I have variants. It's how big they are. The smallest you can be is a single base pair, and the largest that you can be are millions. Like Down syndrome is tens of millions of base pairs that are duplicated, the entire chromosome 21. Most variants are on the very small side of the scale. So 1 base pair. SNPs are all 1 base pair. So this is prevalence. This is how common it is. It's very rare or very common. I see the bottom of the slide got cut off. In fact, a lot of the slide got cut off. I wonder why that happened. Oh, anyway. It won't advance. Sorry. Okay. One back.
I think it got zoomed in.
Okay, I'll try not to touch that anymore.
That must have been that thing.
Okay, all right, thanks. The purpose of showing that is that there's different technologies. The smaller variants are picked up by sequencing, And the larger variants are picked up by microarray or some chromosomal microarray or chip technology or something like that. Now this is somewhat an old slide because today we use whole genome sequencing and it picks up all variants of all sizes. But most places, including most universities, still do exome sequencing, if at all they do that at all, and which gets the little variants, and they do microarray, which gets the big variants. So most places that you'll go, they'll use this technology where you need two different ones. You see there's a tiny little area in the middle that you can't get by other. They don't overlap. You can't just do one and not do the other. Variants can be big or small. And if you had one of these done, you've only looked at half the possibilities. Okay, so I'm talking now about what are called copy number variants, or CNVs. These are the large mutations, all the ones over here that are picked up by microarray. So CNVs often considered to be chromosomal abnormalities, but we can get much, much smaller than that. These are the chromosomal abnormalities which are most common in autism. And you see the number on the left is the chromosomal location. The top is 16p11.2. So that's chromosome 16, the P arm, which is the short arm, and band 11.2. And then there are 3 years ago, when I first made the slide, there were 79 studies in the literature that showed that that particular variant, that deletion, is associated with autism. There's far more now, but it's just, that is associated with autism. And then you can see that those are the most common ones, but there's actually about 1,000 or so chromosomal variants or copy number variants that are associated with autism. So these are hundreds to millions of nucleotides in size. And they can either be de novo. De novo just means new in Latin, meaning that they're not in the, so this is where I use the mutation word. They're new mutations. They've occurred in the child, and that they're not present in the parents. They can be de novo, or they can be inherited from a parent. The very large ones, what people think about as chromosomal abnormalities, do often have things like intellectual disability, dysmorphic features, seizure disorders, small size, and birth defects, things like that. And you can see that they're on that slide there. But those are the very largest ones that are hundreds of thousands of nucleotides large. You can have copy number variants or large mutations that aren't super large, that don't look like that don't have any of those chromosomal type qualities and look exactly like very small mutations. So it's really important to look at the large mutations as well as the small mutations. I'm just going to show you two of them, just to give you an idea of how these things work. The third most common one is the 22q11.21. Before the molecular age, there were many different syndromes that were called that because people would base it on you have X, Y, and Z, you have such and such a syndrome. But this deletion means a part is missing, causes many different syndromes, including DiGeorge syndrome, and I've got many of them on there. But the way that it causes disease is not the chromosomal arm that it's on, but which genes. If the deletion involves the COMP gene, you get behavioral changes. And you can often get mental health disorders, including schizophrenia. If it involves the TBX1 gene, then you get heart disease, like you see in DiGeorge. Then the heart doesn't form correctly in many cases. Other genes in that area cause other things. You can see there's a really big, long nose. That's characteristic of that deletion. And other genes cause that. So the thing is that when you have a chromosomal abnormality, people say, well, I have a deletion on 2q. Well, 2q has 100,000 genes or so. It's like, which ones are missing? And because each gene causes different situations. So you have to look at that. People say other things is that, okay, you know where it is, but you can't do anything about it. That's not true. I had a patient, a well-known autism doctor had called me up and had a patient that had this deletion and they couldn't find anything else on it. And it was a teenager who had autism, high functioning, but he stopped talking about a year ago and he's now 18 years old and no one can figure out why he stopped talking. And they said, okay, well, this probably is it because this deletion is a very high risk factor for schizophrenia. And when you have a 17, 18-year-old who stops talking, that's a very high risk factor. And that turned out to be the diagnosis, so that it does sometimes help to figure out what's going on. I show this one because this is in the ancient time, like a few years ago, geneticists had to measure the eyes, measure the hands, do a million different tests, look at the kid, look at the books and everything, and try to figure out what it was, and then do a bunch of tests. This is the only now what we do is we just do whole genome sequencing. We need to still look at the child to be able to see what in the sequence makes sense and what doesn't make sense. But this is the only holdout, because the test for this, the whole genome sequencing, will find pretty much everything that causes autism except for Angelman syndrome. So this is still a holdout from the ancient days in which you have to suspect it based upon clinical. The thing is that this is an epigenetic disorder. It's an abnormality in the methylation of the genes. And you need to do methylation testing to find it. It's a separate test that needs to be ordered. You can get, if you have autism plus epilepsy, particularly if you have kind of bizarre laughing, maybe laughing seizures, or the kid laughs at inappropriate times, then that's to suggest it would be Angelman. Other things about Angelman is that they have ataxia, or walking like a drunk person. So those are some of the things that will help. Okay, now back to this graph. Last time I looked at it from small versus large mutations. Now I'm going to look at it as common versus rare. Now, if it's very rare, like it's never been seen before, or it's 1 in 100,000 people, it can be the main cause of disease. And then we can call causality, or very highly related to the risk of the disease. But the vast majority of variants, if they're associated with disease at all, are risk factors. And they're often inherited from a parent who's unaffected. So risk factors can be common, they can be rare, or they can be anywhere in between. Most of the abnormalities that I'm going to be talking about, most of the genetic variants I'm going to be talking about are risk factors. In fact, the 22q11 is a risk factor. I've seen 22q11 in completely normal people. Once I saw it in the father, who was an engineer, and totally normal except he had a raspy voice. And that is a sign of 22q11. But otherwise, everything was normal with him. See, it's a risk factor. It doesn't cause disease. The TRAP1 variant that I mentioned that's in 1% of the population, that's a risk factor. It doesn't cause disease. So what we're mostly looking for are risk factors. Okay, I mentioned before about Denovo. Denovo are new variants that aren't present in either patient. So it's a new mutation. It's occurred somewhere between the formation of the gametes and the formation of the embryo, the early embryo. And what it means is it's not present in either parent. In reality, it means it's not present in the saliva or in the blood. There's a small possibility that it's in the testes or the ovaries, and so the recurrence risk is not 0, but it's considered to be 1%. But if you have a de novo variant, then you know that the likelihood of having another child with this is very low. It's less than 1%. By the way, autism risk factors are actually quite high. They go as high as 25% or more in general. So that makes a big difference in terms of family planning if you have a de novo variant. About 1/3 of patients with autism have de novo variants that are in many cases the main cause of disease, and other cases are major risk factors. It's not rare at all. It tends to be the lower functioning ones. Among the very low functioning ones, I'd say the majority have de novo variants, not much higher than 50%, but probably higher than 50. Among the high functioning autistic population, it's not 0, but it may be 10% or so. It's much less. And in between, they're in between. So in patients that are moderate to low functioning, I always recommend trio or sequencing of the parents, and I'll get to that later. In patients that are very high functioning, it's not totally necessary, and a lot of times we can get away without doing it. It's a cost issue. So that's what de novo mutations are. Inheritant variants. Remember I said that it can be in a normal parent. These variants are risk factors to disease. Some of them are low risk factors for disease, but a patient may have a lot of them. And they are inherited from each variant is inherited from one of the parents. Sometimes the variant is inherited from both parents and the child has a double dose of it. They predispose, they don't cause disease usually. Environmental components are extremely important in inherited variants. They're important in de novo as well, but they're very important here. Recurrence risks are high because one of the parents has the variant. And family members that have the same variant can be completely normal because it causes risk for disease. It doesn't cause disease. Risk factor variants can, of course, cause risk in two different people. So you can have two siblings with autism or one parent with autism and a child with autism. It can also cause other neurodevelopmental disorders because remember, these are not autistic genes. Someone else in the family can have epilepsy or ADHD or something else with the gene. But what I see very commonly are form-frust phenotypes. That's a French word. It means that it's decreased in form. And like the engineer that I mentioned, that was completely normal except for had a raspy voice. That is a form-frust. You can't say he's completely unaffected by the deletion, but certainly doesn't have disease from it. So you can have people that, I know that this is somewhat stereotypical, but I come from a family of engineers, and I might be a little nerdy myself. And often people say the form-frust of autism is an engineer. One of the things that I talk about to my adolescent patients is name a billionaire, and that person likely has Asperger or high-functioning autism. Form-frust of autism is not a disease. It actually people with that are able to focus better on school and on their career. They're very creative, and they often do great things in society. So it's very common, and probably a lot of people in this room right here know of one parent, or remember, these are risk factors. It can skip generations. Maybe a sibling, maybe an uncle, maybe a niece that is a little turned inward, a little nerdy, and probably very successful in what they do. If you were at my other talk, I spoke about Zach, but I know a lot of you probably weren't, so that I'll go over that. Zach has autism. He regressed at age 18 months. No known trigger, no vaccination, no illness, no surgery, nothing that we can tell on that. Autism with regression is often mitochondrial or channelopathy or neurotransmitter. It increases the chance that I'll find a genetic variant quite a bit. He had cyclic vomiting syndrome, dysmotility, headache, muscle pain, severe exercise intolerance. Rhabdomyolysis is that the muscles break down. But what I put there in color is complex regional pain syndrome. His right foot, I believe it was, became swollen and purple, and he could not walk. He could not even stand up. He could not put a sock on it. If you just touched the foot, he would scream and become violent. He had very severe complex regional pain syndrome. Of course, he got lots of MRIs and x-rays, and everything came back normal. And he was in that state, completely disabled, unable to bear weight for a year and a half on 3 different narcotics at very high doses with a lot of side effects, and still in tremendous pain. And that's really what complex regional pain syndrome is. I put him on the mitochondrial cocktail and amitriptyline, and the complex regional pain syndrome completely went away. He was able to run and jump and do everything, able to wear shoes and socks, and he went off of all of the narcotics. His cyclic vomiting syndrome went away, and he stopped breaking down his muscle. But his autism continued. It was no better or no worse than before, but he was better. He had more than 25 hospitalizations a year, between 25 and 50 hospitalizations each year. He went down to 2, both of them for bowel problems. His bowel problems did not get better, nor did his autism. And then later we did genetic testing. That's where I left it off last time. Found a variant in the chat gene, a variant that's also seen in 1% of the population, but I had seen this variant in other patients that had a lot of pain issues in particular, but also mental status problems. Zach would have times in which he would seem like he was completely out of it, like almost comatose, and would just stare off, and they would last for hours. He would also have very severe dysautonomia, and severe reactions to anticholinergic medications. So that I'd seen this before in 2 other patients at that time. This is the gene that makes acetylcholine. Acetylcholine is a very important neurotransmitter in the brain and also in the muscles to make the muscles move, and in the autonomic nervous system. And it appears in polygenic disease as a risk factor. It's not the cause of disease. So the problem is you can't make enough acetylcholine. I can't make him make more acetylcholine, but I can keep what he has in the synapses longer. So I used Aricept, which is a drug which blocks the enzyme which destroys acetylcholine. So it blocks the destroyer. So in other words, you have the acetylcholine last longer because the protein that's supposed to break it down has been blocked. On that, the mother told me that he was talking. And I was saying, that's nice. I'm glad that he's talking, and I'm thinking she's a little cuckoo or something, because, I mean, Zach doesn't talk. He might repeat what you say, a couple words or something, and any question you say, he'll say yes, but he doesn't talk. And I saw him, and he was speaking to me in full sentences. I couldn't believe it. I would not have believed it if I didn't see it. And it's not that I didn't trust his mother or something, it's just like, no, Zach doesn't talk. But he did. It made a big difference. It's finding variants, and in this case, it's not the main variant that causes it. He has a mitochondrial disorder, but finding a variant that modifies the disease and treating that made a big difference. I also spoke about Luca at the other talk. Luca had profound hypotonia, and he lost his language skills at 9 months following the routine 6-month vaccinations. He also has seizures. 1 in 3 patients with autism also have epilepsy, so that's pretty common. GI issues, chronic fatigue, that's really, really common in autism. So, and then, of course, future vaccinations were withheld, which isn't easy to do in California, by the way. And he had substantial improvement in the mitochondrial cocktail, which I spoke about in the nutrition talk. His seizures got much better, and GI issues and everything. And later we did DNA sequencing. What we found is a variant in the sodium 1A channel. S for sodium, CN for channel 1A. It's a sodium 1A channel. If you remember basic biology, the way that a nerve cell fires is that a sodium channel opens up, sodium rushes in, because sodium is pumped out of the neuron actively using ATP. When the nerve cell fires or discharges, the sodium channel opens up, sodium rushes in or salt rushes in, and that causes the electrical properties of the neuron to change, and that's how a nerve fires. That's how it sends impulses. This is that channel. Sodium 1A is the main channel for which sodium rushes in to cause nerves to fire or discharge. This is how nerves work. The variants in this can cause epilepsy, they can cause autism, but they also can cause vaccine-related disease progression. And that's something that we're fighting out right now in vaccine court in Washington. I have another case. I'm going to go buy another round there and try to convince them that a sodium 1A mutation caused the predisposition for the vaccine-related injury in that patient. The government has acknowledged the fact that sodium 1A is associated with vaccine-related injury. The government has not acknowledged that it makes a difference because they say the patients would have gotten to the same place anyway. I have to show them that that's wrong. The family had been withholding all vaccines in the brother, who has some hearing loss but is completely normal and is a gifted student in school. He's now in middle school. And I found that he doesn't have the sodium 1A variant, so that made a difference in him. Now, I want to mention that, I mean, the vaccination is, I mean, there's certainly one opinion here, and most medical conferences is a very, very different opinion. I'm a moderate, so both sides may consider me the enemy sometimes. I recognize the fact that there are vaccine-related injuries. I see it all the time in my patient population. I also recognize the fact that vaccines are important, and I try to balance the two of them together. The interaction between genes, vaccines, and everything is extremely complicated. I truly believe that it's the perfect storm. It's not just the genes and the vaccine, but it's the Tylenol, it's the viral infection you got in the pediatrician's waiting room, it's the vulnerable age of the child, and the fever and many other factors. And the ones that I've seen that have gone to court and everything with the really egregious thing, usually there's many, many things piled on top of the other. And so what I do in my patient population is I remove the risk factors as much as possible and vaccinate in a slow and very methodical method. So far, no one's gotten hurt by that, and I hope that continues. Okay, so what do we mean by genetic testing? Not that long ago, like 20 years ago, the only thing that we can do is to test individual variants. That would be like there is a known variant in a gene, the common mutation. So like there's a common mutation of Fragile X. That got cut off from the bottom of the slide. And I've given this talk before and it never gets cut off, I'm sorry. Something about this computer or something. In Fragile X, it's an expansion in a gene, so you test for that one piece of that one gene. That makes sense if you really think the patient has Fragile X, but only about 1 to 2% of autism have Fragile X. Worth testing, but it's unlikely that you'll find anything, and if you had Fragile X testing, you can't say, oh, I've had all the genetic testing that I need. Then we went to single gene sequencing. Instead of just looking at one piece of a gene, we could sequence an entire gene. That was around the turn of the century that became possible. It cost $3,000 to $5,000 a gene because it was a lot of work. Then we went to small panels. Like with Rett syndrome, there's like maybe 4 genes that were known to cause Rett syndrome. There may be 10 now. So you could put 4 or 10 genes on a panel, and you can do those. So when things got cheaper, instead, you can't do that at $3,000 a gene, but when things got cheaper, you can offer a panel for $3,000 because sequencing got a lot cheaper. When I was at Cortigen, we had large panels. Panels were a few hundred to 1,000 genes. And yeah, panels were like $18,000 or so, but if you think about it, you're doing 1,000 genes for $18,000. That's a lot cheaper than we were doing 5 years before that. And you can do a panel for epilepsy or autism, and what the problem with that is of course, the number of autism genes just keep increasing every moment. And we were constantly increasing the panels, and no matter when you got it, it was late. I mean, because there was, yesterday there were things found, even if it was a brand new panel we were just selling. So pretty much the whole area has gone to exome now. Exome is all 23,000 genes. So it's not like we're going to find another gene later, it's all of the genes. So exome sequencing now is pretty much the standard in most academic centers. In private practice, they rarely use this. So I'm trying to get more and more sequencing in private practice because I think that they deserve it as much as the academic centers. It is really kind of the standard, but it's emerging for whole genome. I do whole genome. Whole genome is all 23,000 genes and all of the DNA between the genes. Yeah, we don't understand the rest of the DNA very much, but that's today. Tomorrow we will, and it won't be like 5 months later, I'm saying, okay, your sequencing was great for 5 months ago, but now it's way behind the times. You need to do this. Once you've done genome, there's no higher because you've sequenced everything. So I'm doing genome, but the main reason to do genome is because the genome sequencing includes the CMA, or the CNV, the large mutations. So exome just does the small mutations. Remember I showed that draft sequencing did small mutations, chromosomal microarray did large mutations. Genome does both. It does everything. So if you do genome, you get both of those. It's cheaper than doing both tests separately often. Plus you get trinucleotide repeats like Fragile X. Plus you get mitochondrial DNA. Plus you have all the pharmacogenetic data that you need to be able to say which drug, which dose sort of thing. And I'll get to that later. So this is, some academic centers offer this, but very few, but this is really where I think that it's at because it's an investment in the future, you get more information, and quite frankly, it's cheaper. So what kind of information, I know that you can't see this very well, this is just to show you the type of output that I get. This is the first 40 variants out of 30,000 variants in this patient. So you just have to keep scrolling down forever to see all the variants. This is in alphabetical order of the gene name. There's information here like what the mutation is on the genetic level, how it changes the protein, if it's been seen before in patients, how it changes the DNA, how it changes the protein. Many different computer programs that look at it and say, I think it's benign, I think it causes disease, I don't know. and then how common it is in different species, how common it is in different human populations. And you can just go on and on and on, and I get all of that information when I look at a variant to determine if I think that variant is likely to be related to disease. So this is just the first 40 variants in this patient. These are, out of the 30,000 variants, these are the variants I thought would be interesting. These are the variants that may be related to this person's autism. By the way, this is Dr. Temple Grandin's genome. So Dr. Grandin and I are working together to understand her genetics, and so that we can, A, understand her, but B, so that we can express it to other people and to show how genetic testing can make a difference. Now, if you haven't heard Dr. Grandin speak before, she's a very interesting person. She does not consider autism to be her disease. She does not consider herself to be diseased. Autism does cause her some problems, but for every problem it gives her strength 10 times over. It allows her to be very creative in her chosen professions. She worked as a professor in figuring out how to work with livestock to make them less likely to be nervous and everything like that, way before she started getting involved in speaking for autism. It really gives her the skills that she needs to become very successful in life, and she does not consider herself to be diseased. And if you call her that, she gets very upset, and with good reason. But on the other hand, when she's standing at the podium, her legs start tingling, her feet get hot like they were on fire, and she can barely even think anymore. She gets tired, and she gets these rashes. And she's had these rashes and this tingling all of her life. And she had pediatricians and adult doctors look at it and give her every diagnosis imaginable, from eczema to psoriasis and a bunch of other things. And no one understood what this was. And it really bothers her. She has 2 known mutations in hereditary Mediterranean fever. Her disease is, her description of the disease is perfect for hereditary familial Mediterranean fever, and it's treatable. There's also many other things in her genome which are also describe different things in her and her family. She'll talk about herself a lot, but she's very private about her family, and her family, like every family, has issues, no more, no less than any other family, and this identifies a lot of the issues in her family. So the genome really makes a difference. But you can see the difference between here. This is just a random assortment of genes, the first in alphabetical order. Green is benign, red is, likely a problem. And, these are the ones that are likely. And many of them are related to her high-functioning autism as well. In particular, she has, in terms of autism, she has a variant in a synaptic protein that holds the neurons together and causes synapses. This protein is, mutations in this protein, sorry, I used the M word. Variants in this protein are very highly associated with autism. So she has actually one of the very common causes or contributing factors. Okay, this is a break for a second. I've gone over all the data and stuff, and I'm going to try to put it together. By the way, I do use the M word in chinchillas. These are my babies. The small one is 4 hours old, and the other 2 are 8 days old. They're half siblings for the father, obviously. And these are my mutant chinchillas. It's not just coat color, but I'm mostly breeding the different mutations together to try to get a more domesticated chinchilla that's calmer with children. So you say, okay, this is really nice, but how much is this going to cost? First of all, insurance plans, if it's done correctly, insurance plans seem to cover it about 3/4 of the time. One of the things to do correctly is it's not creative coding in that it's fraud. It's coding, appropriate coding, in that things like epilepsy and hypotonia that are more likely to be covered by insurance companies are put as the #1 diagnosis, and things like autism, which are less likely to be covered, are put as the #2 diagnosis. And personality things or intellectual stuff like learning disabilities and intellectual disability and things like that are put way down on the list if you put them on at all. So coding makes a difference, because the computers and the insurance companies, they just look at the codes. It also, a letter of medical necessity makes a difference. What the insurance company wants to see is that this is an important situation, that this patient is affected. The other thing is it wants to see is that other tests have been done. That so the letter of medical necessity should discuss the patient, why it's important to do it. I have templates that I use, so it's really not that difficult. It's enter here all the tests that have been done, enter here why this patient is really disabled by this condition. They want to see that there's something there that is not just anybody with a learning disability that they're paying money for. And so insurance will pay for it most of the time. Now, sometimes insurance won't pay for it because the type of insurance that you have, or for whatever reason they reject it. Cash prices have come down dramatically. I show some of them up there, or some of the cheaper prices. If you do trio, which is both parents and the child, it doubles the price, not triples the price. So you have to consider that, and there's also the interpretive costs. If you have the hard drive filled with genetic data that no one can read, it doesn't help anybody. So you have to consider the cost of the first going to the physician that's going to read it and having the reading and everything in the follow-up. Okay, so recommendations. First of all is to sequence all the genes, which is whole exome. For small mutations, CMA for large mutations, mitochondrial DNA, because mitochondria is very important. It may only be 37 genes, but they're often very highly expressed in autism. A lot of times it's mitochondria, but most importantly, mitochondrial disease is treatable. Fragile X, maybe only 2% of autism, but you don't want to miss it. Pharmacogenomic testing, that's where you say this drug is unlikely to work in the patient because of the genetic testing. These are the SNPs. Or that this drug is metabolized very quickly, so you have to use a higher dose. You may have used a normal dose and it didn't do anything, use a higher dose. Or the drug is metabolized very slowly, in which case a normal dose may cause a lot of side effects, and you start with a quarter of the normal dose or half the normal dose, depending on the situation. So this is important as well. So these are the tests that I think that should be done in autism, but whole genome sequencing will cover essentially all of that. So it is an alternative. Big question is trio versus singleton. I'll get to on the next slide. And then Angelman testing, like I said, if it looks like Angelman testing, that's a separate case. And the one that got caught off in the bottom is the expert interpretation. Okay, should you sequence the parents or not? In a child with high-functioning autism, you can probably get away without doing that. If cost is an issue, I would just sequence the child first, and if you find something, great. If you don't find something, consider sequencing the parents at the same place. If the insurance company will pay for it, it's best just to do it all up front because it's unlikely they'll go back and then do the parents later for a second one. So I would suggest if the insurance company just put it through as trio, and if they say we won't do the parents, then go for singleton. But anything moderate or more severe in terms of autism, you really need to do trio. I've had many patients before, many families do singleton testing. We didn't find something. We went to trio and we found something. Because we're looking for new mutations which aren't present in the parents, and they're not always obvious when I look at the child. When I showed you Dr. Grandin's thing, we can't do her parents. She's in her 70s. Her father has been dead for a long time. But there were about 40 different variants in her genes that could very well be de novo. And if one of them is de novo, then that is very likely to be the cause of her issues. But we'll never know. The disadvantage, there's also other advantages of trio. I mean, like if there's a bunch of problems on one side of the family, obviously you're looking for genes that came from that side of the family. Disadvantages, it's the price. It's about double the price. If your insurance is paying for it, I think that it's something that you should do because it really does help. If you're paying cash for it and the price is an issue, again, I mean, you can start with singleton, particularly in a high functioning case. The logistics of getting both parents. Not every child has two parents available. Adults with autism many times don't have both parents available. If you do not have both parents available, then do singleton, because looking for de novo requires both parents. You do get some advantage of seeking one parent, but not nearly as much of an advantage as the cost. So, in other words, trio for severe cases, trio also for epilepsy, and syndromic, dysmorphic facies, multiple birth defects. So, I mean, legally, only a physician that has seen the patient can order genetic testing. So it would have to be the treating physician. Now, however, after having said that, I think in most cases that trio genome sequencing, whole genome sequencing is the way to go, and that you can suggest to your doctor that may be what he or she wants to order. The main question is who will interpret the test, because you get a lot of data. When you do trio genome, the information is so great that you would have to take an entire hard drive from a desktop computer and mail it to send that data. It cannot be, there's no way that any of your computers that you have, unless you work for Google or something like that, could handle that much data in the computer. It would take up all the memory and it would crash the computer. So what it's done is it's on the cloud is where the data is, because there's only like the major servers can possibly handle that much data. So this is a system that you see that the top no longer says neuroneeds, it says CNNH. CNNH is a group of pediatric neurologists for the most part, but they do see adults. That's in the Philadelphia area. They have 3 locations, 2 on the New Jersey side, 1 on the Pennsylvania side. Even though I live in Pasadena, California, I joined that group because I thought that they were the best. And they really use genomic information. So I am a 1-day-a-week employee of them, and I connect by telemedicine. So there are 2 ways in which that this can be done. The main way that we do this is what we call the peer-to-peer, or the P2P, and when I abbreviate it, counseling service. This can be done anywhere in the world, and I've done it in many states as well as in Poland and Israel so far. What it is that your doctor contacts us and says, I'd like you to help us. Here's the paragraph on the patient. What test would you suggest? Of course, it's up to the doctor to order it, but we can suggest testing based upon the individual patient. Then we help them get the data from the testing lab processed so that I can read it properly. And then I read it, and I go through it, and I write a report on it. And then I discuss it with the doctor on the telephone. I said, okay, please tell me about the patient, because the genome is worthless without the patient. You need to connect the 2 together. And that's the problem with laboratories, is they don't have the patient with them, and they're doing their best guessing. I was the medical director of a laboratory before. I was in that position. I know it's really hard when you don't know the patient. So the doctor talks about the patient. We go back and forth until I feel I have a good understanding. Then we talk about the genomic findings. We go back and forth until your doctor has a good understanding of the findings. Then we discuss which ones are likely, which treatments are possible, and we go back and forth and kind of come together, the melting of the minds. Okay, these are the ones that are likely related to disease, and these are some of the treatments. Here are the pros and cons of these treatments. And then it's up to your doctor to go and discuss it with you as to what the pros and cons are. If it's in a state in which I have a medical license, you can be involved in the process. You can either be in the room with a physician, or it can be a 3-way telemedicine call on the internet. If it's in a state where I'm licensed and it's on the list there, it's underlined about 2/3 of the way down. Arizona, California, Florida, New Jersey, Pennsylvania, South Carolina. Then I can ask you questions and you can ask me questions, and it works much better that way. Because the doctor and I often don't know, are the ears big, or was the thyroid testing, what was it, or something. Even if the chart in front of us, we often don't know, is there a family history of cardiomyopathy? These sort of things, it's really good to have the family there. I try to do as much as I can for the patients without going to jail. So you have to be in a state where I am licensed. I have had many families before go see grandma in Florida, where I'm licensed. I have had families drive across the bridge, park, and say, okay, we're in Jersey now. Unfortunately, lawyers don't trust anybody, and they have put it on the internet. I know exactly where you are when you hook up. When you hook up to the internet, I know exactly where you are. So you have to actually be in one of those states, or I'll know otherwise, because I have to copy and paste it from the thing and put it into the chart. That was not my suggestion to do. That's the lawyers that looked at what we're doing and said, you have to make sure they're actually in a state, because people can just say they are. I was okay with the other, but anyway. So that's the peer-to-peer system. Another way to do it is to go see the neurologist at CNNH and who are excellent, and they can order the testing and everything, and I will join you by telemedicine when we go over the genome and discuss all that. And another way is direct telemedicine, where if you're in one of those states, whether you live there or you traveled there, you just meet me on the internet on a telemedicine call, and then I'm the physician throughout the whole thing. So there's different options in different situations. And if you're interested in that, then Lori is the person to talk to, and she's at the bottom, and I've put down her email address, which is the penultimate line, and just beneath that is the website for CNNH, and then if you push the genetics button on the right-hand side, you go to the program. So does this really make a difference? Just last month, Dr. Mintz, who's the main neurologist there, the one that runs the center, he was the first author in a poster at the American Academy of Neurology that was in Philadelphia just last month. We discussed the first 17 patients that we had done. They were 8 different physicians in 7 states and 3 nations. I know that doesn't add up very well. I can't figure that one out. Anyway, 6 different genetic laboratories had done the sequencing, and the results are on there that it altered the physician management in 16 of the 17 times. Most interesting, in 9 of the 17 times it gave an exact diagnosis. This is what your child has. This is the name of it. We found a pathological mutation. It recommended changes in therapy 15 out of the 17 times, and indications for additional testing 7 out of the 17, and indications for outside consultants in 4 of the 17. A lot of the insurance companies and people are worried about, you'll do genetic testing, you'll find a whole bunch of garbage in there, you'll send them to all these doctors to figure it out. It was only 4 out of the 17 that had any referrals to somebody else. So, I mean, we might find something that we can't handle ourselves. But, and those were usually cardiologists or immunologists. Particularly, a lot of the patients with autism have a lot of frequent infections, and we found something in the genes that looked like it may be the cause of the frequent infections. We're not qualified to do that, so we say go see an immunologist and see if there's something that can be treated about that. I put this slide together before a talk that I gave in March. It was to talk to doctors, and they want to say, tell me about how often, the last 7 patients. So I found the last 7 patients with autism. One of them has ADHD, but they all have neurodevelopmental disorders. 4 of them are for my own practice in Pasadena, and 3 of them are for Dr. Mintz's practice as part of CNNH in New Jersey. And I found the exact cause in all 7. That's really high. I had a good month. It's about 50-50. And all 7 of them I changed the management. Some of them I know got better, some of them I haven't heard back from. That was March. Okay, so why do genetic testing? Well, first of all, is the right therapy may not be a drug. It might be cyclocreatine, or it may be a mitochondrial cocktail, or it could be many different things, but it may not be a drug. In case of the sodium channel 1A, cannabis is often the treatment that's recommended. So the right treatment may not be a drug at all. If it is a drug, and sometimes you did see that, I'm not afraid to treat with drugs. I use Kytril in one, I use Aricept in another. Use the right drug, not just any drug, not just, there's a lot of drugs that are used in autism. To use the drug which is indicated for the mutation, for the variant that is thought to be pathological in that patient. And then there's the right dose. That makes a big difference. Okay, you're a slow metabolizer. We're going to use a very low dose at first because we don't have side effects, and then you move up. Or you're a fast metabolizer. We're going to start with the normal dose, but we recognize that if that doesn't do anything, that doesn't mean the drug didn't work. We'll double the dose later, maybe even triple it later if there's no side effects. Of course, also having a name for the disease can help. You have a name, you have a reason, you can know information about it. It seems to make a big difference in getting services from a university, if your child gets old enough to go there, from insurance companies, blah, 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 everything. If you have a name, it seems to be more legitimate, which makes no sense at all. Your child is your child, regardless if there's a name to it. But I can't change everyone. Okay, here's the ugly fates again. Okay. I showed that at the very beginning of the first talk that I gave. If you haven't been there, the fates, from ancient Greece, that they take they spin the silk of your life, and then they measure it to see how long you'll live, and then they cut it, and then you die. And it doesn't matter how great of a hero you are, or what your deeds are, or whatever. When your time has come, your time has come. You can do nothing about it. A lot of people think about that with genetics, or are afraid to go to a geneticist because I'm going to measure the silk and then cut it for you. No, it's that genes are there, you can't change it, but you can change gene expression. The environment is what turns genes on, it turns them off. The environment makes a tremendous difference. Environment can be a viral infection, it can be a surgery, it can be an injury, it could be a vaccine, it can be a toxin. These do cause genes to turn on and off related to disease, but they can also go in the opposite direction towards healing. It makes a big difference. To use an analogy, let's say that you're a poker player and you have a hand of poker. The genes are the cards in your hand. You can do nothing about that. Those are the genes that you have. That's your hand. The environment are the hands of your opponents. Your genes have to maintain homeostasis, to keep you healthy. The environment is adverse, and particularly lately, it's very adverse, and your genes need to make up for it. But who wins the hand will not just depend on the cards that have been dealt. It will depend a lot on how well you play your hand. So know the cards that are in your hand. You can't change them, but at least you can know what they are and know how to play them the best that you possibly can. And here's the last slide here. This is my information for the NeuroNeeds, for the CNNH Neurogenomics program. I showed you things before. My own private practice in Pasadena, California. I also, in my private practice, do telemedicine in Arizona and Florida. The NeuroNeeds booth, which is like a 10-minute walk from here on the other side of this place, is right outside the main auditorium where Bobby Kennedy spoke. That's where I'm at, and I'll answer some questions here if there's any time, but I think I used up all my time, didn't I? Okay, so I'll go over to I'll be outside for a few questions, then I'm going to go off to the NeuroNeeds booth. That's where I sit. If you have any questions about genetic testing, about what would be the appropriate testing, about all the different options I told you about, they're confusing which one you want to take. And of course, try the NeuroNeeds yourself. It really tastes good, and it makes a difference in the kids. Thank you. Okay, yeah.